Hi everybody, my name's Jo Ferris. I'm the operations manager for the Association of the British Pharmaceutical Industry in Wales. Delighted to have everybody here today. John's asked me to chair the meeting today. I'm part of the steering group that supports the Welsh Life Sciences Hub Innovation Network, and we've been working with John over the last couple of months to look at how these meetings are delivered and looking at different themes that we can look to over the next year or two. We've got a really packed running order today. I saw it come through and I did say to John, we really are going to have to take a break at some point, because I'm not sure at this point that I can do nearly 2.5 hours on screen without needing a little break. So we will take a break at some point. But we're delighted to be able to welcome colleagues from across Welsh Government, across industry, and across some of our supporting areas like CEDA to today's meeting. We're also going to have a couple of pieces from the Welsh Life Sciences Hub themselves. And I think we've got Catrin Isaac Rees with us from the Hub.
Hello.
And Catrin, I think you just wanted to say a few words at the beginning about a really exciting new podcast that you're organising.
Yes, thanks, Jo. So hi everybody. So we're currently recording our second series of our Healthy Thinking and Syniadau Iach podcast. So it's a bilingual podcast. So we've got a few episodes we've recorded so far, and we've welcomed some guests from Gyfer AI, the Yorkshire and Humber AHSN, the European Connected Health Alliance, and Delta Wellbeing. So each one of our podcast episodes focuses on a different topic. So now we're looking to record the Welsh versions of those episodes, and we're looking for colleagues in the healthcare innovation space with projects and expertise in assistive technology, sustainability, and the ethics of data in healthcare. So I just wanted to pop on just to see if anybody had any interest to get involved, or if they knew any colleagues who wanted to be involved. The only thing is we ask they are Welsh speaking. So I'll pop my details in the chat, and if you just want to send me an email, we can have a chat about it. I'd be very, very grateful. So thank you, diolch.
Thanks, Catrin, and I'm sure colleagues will put things in the chat as well, and John and you can follow up with them afterwards if there's interest in that. So thanks for that. We're talking today a lot about access and a lot about getting, and one of the things that we're very keen on doing at the ABPI is ensuring that our members, and I'm delighted to see so many companies on the line today, so lovely to see you all guys, is going to work within our code of practice collaboratively and jointly in Wales, and all of these things are going to sit under, I feel, some really exciting new work that's coming out from the Welsh Government. I'm delighted we've got Abby Phillips here, who's going to talk about the integrated innovation strategy, and then Tom, who's back from the NHS and back into Welsh Government, so nice to see you, Tom. He's going to be looking at the Health Innovation Programme, so we're really pleased to have you both here. I won't do any introductions, they'd probably be entirely inappropriate from Abby and Tom's point of view, so I'll let them introduce themselves for those of you that don't know them. And we'll look forward to being able to have some questions. Abby, I think you're just staying for your part of the presentation. Have I got that right?
Yeah, I'm here until 2 o'clock. So Tom and I are going to try and canter through the strategy stuff to give people an opportunity to comment. But rest assured, we do have a dedicated email address for anybody who doesn't get an opportunity today and would like to feed in, and there will be future stakeholder engagement opportunities. Wow.
That's brilliant, and somebody will pop that in the chat for members just in case we don't get there today, because I know you're on a bit of a tight deadline, aren't you?
Yeah, that's great.
Brilliant.
You want me to share my slides?
I'm gonna look at Priya and hope that I know Priya's got the slides.
I have the slides, Abby. Did you want me to share them on your behalf?
Yeah, that's perfect.
No problem, bear with me.
Okay. As I said earlier, so I'm Abby Phillips, Head of Innovation for the Welsh Government, based in the Economy, Science and Natural Resources Department, and I am leading on the development of the innovation strategy for Wales, along with lots of other colleagues from across. Just move on to the next slide, please, Priya. On policy making in Wales. I'm sure you're all familiar with the wheel on the left-hand side of that slide. That is the Wellbeing of Future Generations Act for Wales, and obviously sets the 7 goals we aim to achieve with our policy making. And then the little diagram on the right is the process we take to develop policy in the Welsh Government. So where we've got to so far in this cycle is the preferred option. So next slide. So how we arrived at this preferred option, we initially commissioned some advice from our Innovation Advisory Council for Wales, and Cardiff University and Amplify, who sit on that council, undertook 2 reports. One, which was a State of the Nation report that looked at innovation in Wales. Where could we go next? What were the types of strengths we had? What should policy, what was the kind of policy context we were operating in? And then Amplify undertook a global report that looked at sort of what are the key features of innovation nations? What are the strengths? What should we be looking at? And those 2 reports have been published and they're available for public consumption. And so I can send a link to those as well. We then took that out to stakeholder engagement. So those 2 reports went to 3 stakeholder engagement events, all digital, and they were attended by around 300 people from across the public and private and academic sectors of Wales. And the broad kind of agreement was, following the recommendations, was that we should pursue an integrated innovation strategy. So people didn't want a business innovation strategy, a health innovation strategy. They were really looking for a kind of government level framework that they could then hang local policy from. So we took that to ministers. They agreed that this was a good approach, and the rationale for that was that it sets a coherent vision. It recognises that innovation is a cross-cutting enabler and tool that we can use to deliver against lots of our kind of policy outcomes. We can actually measure collective impact from this. It gives us an impactful and coherent message with international partners, and sort of those collaborative opportunities that come up. And it was recognised as a tool that could deliver much of our kind of new programme for government. So we set about looking at what are we going to try and achieve with this? What outcomes are we looking for? And we've done a bit of a logic modelling exercise, which is currently in draft, soon to be published in final version. We're aiming for publication in spring 2022, which is an ambitious time frame, and we are currently in drafting phase. And this will align quite nicely with the kind of winding down of EU funding programmes and the ramping up of whatever comes next. Next slide, please. So just to give a very, Priya, just to give a very kind of brief sort of update on the UK government innovation strategy. So published last July, I'm sure you've all read it cover to cover, but they had the 4 pillars, very much a business innovation strategy and looking to make the UK a global hub for innovation by 2035. So their aims are really to kind of unleash business, driving that investment in innovation up to the 2.4% of GDP, and how they'll do that, around sort of using public investment to stimulate that activity and kind of regulation change, and various other reviews that they've committed to take. They also want to develop people, not just the homegrown talent, but also attracting the best talent from overseas, and they'll do that with kind of scale-up visa routes, and then lots of kind of institution and places. So some of you may have been involved in the nurse review, which is currently underway, which is looking at the research, development and innovation landscape across the UK. There's some funding there that's been committed to deliver. And then the sort of pillar 4 is really that kind of legislation that we're seeing coming through for ARIA, which is all about those kind of moonshot missions and how we invest in that as a kind of UK, alongside the 7 kind of technology families. Next slide, please. So I always think it's nice to have a little look back, and we will be doing that as part of the innovation strategy as well. So what did we achieve from our previous innovation strategy, which was primarily business, Innovation Wales? And here are just some of the kind of outcomes and outputs that we have got from various evaluations. And you'll see there some of the health stuff that we've invested in, carbon reduction, and some of the funding that we've achieved from European and UK sources. I think there's a lot of learning to be taken from this, and this will feed into the kind of strategy as we develop it. So just to give a couple of examples, we have managed to secure 264 million from Innovate UK across a number of projects. However, 70% of that funding has been awarded in the Cardiff and Swansea areas, whereas when you look at the Welsh Government interventions, they're much more evenly spread pan Wales. Another area which is kind of, you know, cause for thought really is the carbon reduction stuff. So yes, we've supported over 4,000 businesses to adopt environmental sustainability strategies, but what does that mean? We don't know. We don't know what impact that's had on their carbon emissions. So how we measure this moving forward is really important. And then obviously from an NHS perspective, you know, 58 technology adoption and development projects funded. What does that mean in terms of the impact that's had on people's health and the kind of delivery of services in terms of kind of resource efficiency and patient experience? Next slide, please. So in terms of work today, as I said, we've done some stakeholder engagement on the initial kind of evidence base. We've just closed our second round of stakeholder engagement, and some of you may have been involved in that, on looking at the logic model and trying to establish with stakeholders, are these the outcomes you want to see? And is there anything we've missed in terms of activities you'd want to see? And that's been published in draft. All of these documents have been published in the same place. We've also done stakeholder engagement summary reports, and they're published for people to see the kind of themes that came out of stakeholder engagement, so that hopefully you'll see that read across right from the kind of evidence base right to the end of this process when we've got the strategy. We've also set up a kind of internal working group for this, and a stakeholder group externally to kind of provide the first point of challenge and advice really. And we're out doing stakeholder engagement like this today with lots of different groups along the way. Next slide, please. So in terms of the logic model, this is the very drafty version. We are currently in design for how this is going to look moving forward. You'll forgive my my drawing. I'm not the creative talent in the team, but this is very much looking at kind of where we are, where our thought processes are, and what kinds of outcomes we're aiming to achieve. This is likely to change because we are currently in the process of collating feedback, engagement sessions, and we will be sort of refining this and publishing it in final version ahead of the strategy shortly. Next slide, please. So I thought it might be just helpful to give you an idea of some of the common themes that are coming up. You know, innovation culture, a big theme coming forward from many stakeholders, and I think really important one to challenge back on. So when asked, you know, everybody says we need an innovation culture in Wales, and I completely agree. When I challenge back on that, I get the same old answers of we need to invest in leadership. But I think there's a much broader opportunity here to invest in people right across the life course, looking like right from education right the way through to leadership, and everything in between. How can we really drive that innovation culture? So really keen to hear people's thoughts on that. Lots and lots and lots of feedback on risk appetites, not least in the area of public sector procurement, and you'll see there that I've included procurement reform, and also managing failure. So how do we kind of manage those messages around failure and the learning we get from that and the values that also represents. Promotion of integrated working and collaboration. So we're really keen to collaborate, and lots of our existing strategies and policies set out this, to our, you know, not least our international strategy that talks about our desire to continue collaborating with the European Union and more broadly. And of course, you know, our existing collaborative activities across kind of businesses, academics and the public sector. Lots of stuff on the kind of climate change, circular economy, resource efficiency and net zero stuff. And of course, the diffusion and adoption of innovation and how we support that kind of valley of death with businesses, but also that struggle that the public sector has to kind of adopt the innovation that comes out of a lot of these projects. That isn't an exhaustive list. That's just a flavour of what we're seeing at the moment, but really keen kind of to hear thoughts on that if anybody's got any, either today or via email. But I'll hand over to Tom now, just to give you a little canter through the healthier section of the innovation strategy. Thank you very much.
Thanks for that, Abby. And thank you, Joe, for the introduction. It's good to be back, actually. It's really interesting working during the NHS, especially during the time of COVID. Good to be plugging back with the Innovation Network as well. I think the last time I spoke to the network was when we published the results of the COVID-19 Innovation and Transformation Study. Can I please request that, Priya, you put my slides up? Brilliant. So my name's Tom James. I'm the Head of Innovation and Technology for the Health and Social Services Group in Welsh Government. I work as part of the Innovation and Technology team. So Jason, Janet and Alex are all members of that team as well. We all manage this work between us. As Abby said, one of the First Minister commitments was, as part of the start of this government, was to look at a new integrated innovation strategy for Wales. And with health as the biggest part of the government portfolio, it's only right really that we have a chapter and a component of the strategy that deals with health and social care. Underneath that strategy, that integrated innovation strategy, we are consolidating and developing a new innovation programme for health and social care. And what I'm going to do is talk to you a little bit about all of that development work as we go through. Next slide, please. So for those of you who may remember last summer, on the 23rd of July, a written statement was made by Eluned Morgan, the Minister for Health and Social Services, around innovation in health and social care. It talked about the importance of innovation as part of the response to COVID-19, a shift to new digital ways of working, improved partnerships between the NHS and suppliers, particularly around PPE, vaccination, technology-enabled care, and a huge amount of collaborative effort from the NHS, local authorities, academic partners, and industry to showcase, lots of strong work and evidence, the sort of outcomes and the projects that our investment in innovation over recent years, through the Efficiency Through Technology programme and more recently set out in A Healthier Wales, was able to showcase. And actually, never has there been a greater opportunity to innovate than a crisis. And COVID-19 brought, one of the biggest crises that the NHS has faced in many generations. Next slide, please. It was important, therefore, that the written statement and our new approach to health and care innovation recognise the good practice, the excellence that our health and care, social care sector had shown during COVID-19. It also recognised the fact that the Efficiency Through Technology programme was written at a point in time, and there was a need to consolidate our existing health and social care innovation activities into a single programme, and to engage with key partners and stakeholders over a period of time to talk about a new health and care innovation programme as part of the integrated innovation strategy for Wales. So what we're trying to do through the development of this activity is look at a tighter focus on our existing activities, strengthen the national direction, lock in some of the changes we've seen, the success that we've seen in response to the pandemic, through publications like the NHS Wales COVID-19 Innovation and Transformation Study, but also work alongside the other devolved and UK government administrations to talk about their approaches to life sciences and the industrial strategy, and to develop a new kind of improved and consolidated innovation programme for health and social care that will allow us to put a stronger national grip on innovation to essentially stimulate further innovation across health and social care. Next slide, please. So we've been working very closely with Abby and the team actually in the development of the vision for a healthier chapter of the integrated innovation strategy, and we've been doing that with all policy teams across Welsh Government. And actually, one of the things that we've been doing is undertaking our own bespoke health and social care innovation impact assessment, which is based on the Welsh Health Impact Assessment Supports Unit's best practice and guidance. This is to ensure that, in the development of new policy, that we're able to consider, the needs and the requirements and the challenges that stakeholders will face, and the likely impact of a new integrated innovation strategy and health and social care programme as we develop those proposals. We know that there is a very strong value-based healthcare movement here in Wales as well, and actually utilising some of their metrics to focus on how we get the best impact from the strategy and the programme is important. There's been huge amounts of work done by the value-based healthcare team to understand what the what the impact of healthcare services are on patient outcomes, patient experience, and resource efficiency. And actually, it only makes sense that value-based healthcare is an underpinning theme within the new strategy and programme. Again, we've been doing some targeted workshops with key stakeholders across health, CumTAF, a regional collaboration for health programme board, so that's the Swansea Bay, Howell and Swansea University partnership, the Social Care Innovation Advisory Group. We ran our own external engagement event on health year just before Christmas, and we've been talking very closely to the NHS Wales Innovation Leads group as the kind of lead practitioners and managers for innovation across their own NHS Wales organisations. Next slide, please. As Abby said, it's really important in developing government strategy and policy to ensure that you have a strong evidence base to look at these things. I mentioned earlier that the evaluation of the efficiency through technology fund and programme, which is essentially the precursor to the health and care innovation programme. So we've been running that since around 2015, you know, at a time when Abby and I and Evan Evans were working in the innovation team in Welsh Government. And actually that got a huge amount of new innovative technology projects up and running right across the health and social care landscape. What it recognised was that what the evaluation recognised was that, you know, we needed an overarching strategy to further guide and to further increase and stimulate the amount of innovation that we were able to offer and to support, but also in regards and in response to publications like the 2018 Reid Review, which essentially says that Wales, because of a lack of strategy and national direction around innovation, or a current strategy and direction around innovation, punches below its weight really when it comes to UK research and innovation funding. So instead of taking around a 5% share, which is a Barnett formula share of funding, actually what we're taking is around 3.2%, which and actually that 1.8% difference is many millions of pounds. So actually looking for those bigger wins, those bigger programmes of UK R&I funding and bringing those to Wales is one of the outcomes that we want to achieve. In June 2021, so coming back to the evidence sources, in June 2021 there was an Achieving Innovation Life Sciences Hub Wales publication, which talked a lot to stakeholders across the sector around, you know, key principles for delivering innovation. We commissioned Cardiff Business School to undertake a study report, so 30 structured interviews took place with key opinion leaders across the health and social care innovation landscape to talk, you know, essentially, you know, what are the strengths, weaknesses, opportunities, threats that faces the health and care innovation landscape in Wales, and how can we learn from that? What sorts of things do we need to put in place to make that a much more conducive environment for innovation, to build on the good work we've done already? So there are research improvement innovation coordination hubs that have been set up through the Transformation Fund right across you know, the different regional partnership board areas of Wales, which are partnerships between local authorities, health and the third sector. And so we've had a number of mapping reports on improvement, innovation and research activity from those areas, Taff, Gwneud, West Wales, and North Wales, and we're awaiting those other reports, which all talk about, you know, to what degree has research improvement innovation, you know, taken hold in these areas. What sorts of evidence bases do we have there? It's a really good base actually as part of the strategy development. In spring 2021, each NHS Wales organisation undertook a University Health Board or University Health Trust designation review, and were asked to submit an evidence paper to Welsh Government on the type of work that they've been doing or what it means to be a University Health Board or University Health Trust in Wales, under 3 different headings. So that was research and development, training and education, and innovation. Huge amount of evidence gained there, which will be feeding into the strategy. We very recently wrote out to each NHS Wales organisation, Social Care Wales and the Bevan Commission in December 2021 to essentially ask them the question, what is it that you want to see as part of a new integrated innovation strategy for Wales? What sorts of issues do you find with the system? Again, strengths, weaknesses, opportunities, threats. Where would you like further support? What sorts of policy, what would you like sort of considered as part of a new policy framework? Those evidence requests are starting to come back in now, and there'll be a really rich source of evidence to provide to frame the strategy. Also, Meddy Wells are doing a report for us at the moment. So this is a refresh of their 2010 Barriers to Clinical Access review. They'll be refreshing that with people, from across the NHS, government, and industry, to essentially understand better, what are the barriers across NHS Wales to procuring and using Welsh-made innovation and technology within the Welsh and health and social care sector, helping us to understand better what to kind of crystallise what those barriers are, but also so we can devise policy interventions, guidance, frameworks and tools to sort of smash through some of those barriers as well. And I think Gwyn is going to be talking about that a little bit later on today, which is good. Next slide, please. So this is the vision, the healthier chapter in the integrated innovation strategy. So that's a health and social care system that collaborates across industry, academia and the third sector to deliver improved healthcare value by developing, sharing, procuring and adopting innovative practice and technology. This approach will prevent illness, support people to manage their own health and well-being, and enable people to live independently as long as they can through the provision of integrated health and social care services which are delivered closer to home. This is very much in keeping with the direction of travel set out within A Healthier Wales, which of course is our long-term plan for health and social care here in Wales. Next slide, please. So some of the proposed themes, and underneath these themes, I've shown some of the organisations that we will like to be working with as part of the development of the strategy and programme. Early feedback so far is that we need to strengthen national system direction through a new innovation policy framework for health and social care. We need to consolidate existing health and social care innovation activities into one single cohesive programme. We need to strengthen the programme delivery structure around that, bringing a tighter focus to our existing activities, but also new activities, being able to upscale and expand the national role of projects where they've shown to be successful so far. And this will build upon the technology innovation progress that we made through the Efficiency Through Technology programme and A Healthier Wales. Next slide, please. We know that a huge amount of stakeholder feedback has told us that there's a huge amount of positive learning to take from COVID-19, and we need to lock those positive changes in to drive, to increase the drive of pace and scale of change in many cases. So where we've seen rapid responses, positive responses in response to COVID-19, what we need to do is do more of that essentially. And what that also means is that we need to target new investment to system needs, challenges and opportunities. We need to understand, as best we possibly can through the evidence sources that we've got, that, what those system needs are, what those challenges are, but also what the opportunities are. I mean, for example, I highlighted the drawing down a greater Welsh share of UK research and innovation money, especially in light of Brexit and the fact that new funds will be made available to across the UK. We've got to make sure that we're able to respond to that. We know that we need to promote and reward innovation better through a range of different financial and non-financial interventions. We need to build innovation skills, leadership and capability at all levels of the system. And we do see a role for the Life Sciences Hub, but also the Intensive Learning Academies Wales for those organisations as part of that. But also, one of the things that we know that we've done some good work in, but we need to do more of, is supporting national and regional collaborations across industry and academia, as well as the third sector, to develop, share, procure and adopt innovative practice and technology at scale and pace where we can. And actually, there is a piece of work that the Welsh Government, Health Technology Wales, and I think the Hub are involved in, which is the development of an innovative devices access pathway, which will give essentially a much rapid, or increased rapid access to new innovative devices as they come through, based on evidence, of course, based on safety and quality, but actually giving them or providing an access pathway for those devices into the health and social care system. And we need to understand, because the Welsh context is different than the UK context in many ways. We need to make sure that we have we ready and prepare the Welsh system to be able to benefit from that. New slide, please. Next slide. Okay, I'll leave that there. I think that's time. Very happy to take questions and comments if we do have time to do that, but also very happy, like Abby, to take feedback on the health and social care elements of this work. My email address on there. I'll put it back into the chat if we need it. But thank you very much, everyone, and it's been nice talking to you.
That's great, Tom. Thanks ever so much. And obviously thanks to Abby as well. I'm not sure whether she's still with us or not, because I know she had a very hard stop at 2 o'clock, but thanks to both of you. I'm about to prove that, there's no such thing as a stupid question by probably asking some rather silly questions. And colleagues, please put your hands up. Please don't hesitate to put stuff in the chat. I know that John's monitoring that for us so that we can make sure that we make the most of having Tom with us this afternoon. So Tom, just to really understand this, I suppose, so Abby was talking about the integrated strategy that's being done across all the departments in Welsh Government, and that's, from a personal perspective, I think that's fantastic to see that sort of integrated approach to that. But underneath that, do we see just programs within individual departments, or will there also be a health strategy? How is it all going to actually come out in the wash, sort of thing, I suppose?
Yes, so the way I described at the start, Joe, is that there's a healthier chapter of the innovation, the integrated innovation strategy, which will be driving delivery of that kind of healthier chapter, if you like, through the health and care innovation program. Okay, it is an integrated strategy, but it does recognise that it can't be fully integrated, otherwise it would just be one, and it would, we're talking about a huge amount of, a portfolio areas across government here. We do have to have some delineation, although there will be common sort of metrics that will apply to each area. For example, reducing carbon emissions, making, looking at efficiencies through technology, for example. But actually, we do have to kind of have our own aspect, our own element of the strategy as well, just to make it practically manageable, I think.
Yeah, and I think that's one of the things this, I think it was Abby spoke about this idea of, what did we get from the money and the time that's been invested so far? So we know that we've got X number of projects or X number of this, but what did that actually mean? And I know, talking to colleagues right across the health service, not so much in social care, I must be honest, but definitely across the health service, there's this desire to understand what difference innovation does make and what the outcomes are, and something we see very much in medicines. I know Abby was keen to say that there's still time to engage, and I know she's put some stuff in the chat, so people who have joined us, there are some things there to go back to the documents, and there's an email address that people can use. But how can people really get involved? I know we're going to go on to talk to Gwyn in a few minutes, but for members of the industry that perhaps aren't in that MediWales space, how can people sort of talk to you about what's going on, or talk to Abby? How does that work?
Well, as I said, we've undertaken a whole range of different external engagement events, but that's not to say that we can have more individual conversations if we need to. So my email address is in the chat there. Welcome people to drop me a line and to have a chat about a bit of the chat about it. I mean, another way to do it is to feed into the MediWales engagement exercise and the barriers to clinical access report, which Gwyn is going to be talking to you guys about in shortly. That's an opportunity as well. But also would welcome the opportunity, if there were lots of industry members, for sort of engaging through the Life Sciences Hub, I'd be happy to run an event with, or a Life Sciences Hub Wales run event, for industry on the strategy and the programme, if that's something, if there was sort of appetite for that as well.
And John, funnily enough, I'm don't know if you can put your camera on or what position you're in to do that, but I think Abby's slides around this innovation culture and some of the conversations that she's clearly been having about how the innovation culture sits both around you know, the workforce and who we get involved in leadership and all of those sort of things. There may be something that the hub, this network, can do to help, you know, Abby and Tom in some of their thinking around that, perhaps more from, you know, sort of a more collaborative way of thinking about it. Do we have any questions, John? I know you were keeping an eye on the chat for me, and
yes, so we've had one question from Henry. Henry, I don't know if you want to ask the question yourself, as in we welcome people to come on to put their mic on and ask themselves, or if I can ask the question for you, up to you entirely. I will take silence as I will ask the question. So Henry said that he's studying an MSc in Logistics and Operations Management at Cardiff Business School, and he asked if you minded elaborating more on the collaboration with CBS and the Bevan Commission, and can students like Henry get involved there?
Yeah, thank you for the question, Henry. I hope your Masters is going well. So this was a piece of work that was undertaken as it was part of an MSc a student's project, and I was offered through Cardiff Business School a 12-week placement for a student to undertake some work for us, you know, through with academic supervision, of course. So this student undertook about 30 key opinion leader interviews across the health and social care innovation landscape in Wales. For us, and as I said, you know, that kind of final project report sits with us, and is currently being analysed as part of the, you know, the range of evidence sources that we have available. The project has come to an end now, but again, you know, if I'd be happy to kind of speak to people, you know, if there's a group of students that wanted to have a chat about the results, you know, when we've done some of that analysis work, I'll be happy to sit down with yourself or a group of people to talk you through some of that. The analysis process is kind of taking place at the moment, so we are putting these evidence sources together and sort of, you know, analysing them together. So but once we're in a position to kind of talk about that compiled evidence, that all of that evidence together, I'd be more than happy to kind of speak to you, or, you know, to a cohort of students if they wanted about this work.
And that's great, Tom, because I think, and I don't know if Henry would agree or not, but I think one of the things that Abby was talking about is not just about leadership, but it's about all the constituent parts as people work through their lives and making them innovative in all the different facets and the roles that they do. Then, you know, having people from some of our very youngest people here in Wales through to master's levels and further will be great. That's no problem, Henry. There's no problem at all that you couldn't join in. So that's fine, no problem. You answered one of the other question I had. I was furiously scribbling notes in the background, and that was how we are working across the UK, because we're very aware, I suppose, in the pharmaceutical industry, there are a lot of the stuff we see is done on a UK basis, coming out of UK government and described as UK, whereas perhaps it's not always implemented in quite the same UK way. So I'm really interested. You mentioned that you are working, and the Minister obviously mentioned in her statement about working across the 4 nations. So can you just elaborate a little bit more on how we're connecting with our colleagues in England, Scotland and Northern Ireland?
Yeah, so we're doing that through a range of different engagement mechanisms. As I mentioned, the UK government is engaging heavily with us on the Innovative Devices Access Pathway, and that work is being led for us by Health Technology Wales, which essentially, Joe, and you'll probably recognise this yourself, is that there's a huge amount of infrastructure that goes with access to medicines, to innovative medicines, between the, you know, ABPI, other pharmaceutical representatives and companies and government, but actually the infrastructure that deals with innovative devices and diagnostics, for example, is not as clear, and there isn't quite a focus on you know, quality and safety as there is, or there isn't a strong enough what's the best way to describe it? There isn't a strong enough engagement infrastructure or a supporting infrastructure for it in the same way that I think there is for medicines. And actually, we've been talking, at senior levels across government, with the Deputy Chief Medical Officer, with, our Director Ivan Evans, the Chief Pharmaceutical Officer, about how can we take the lessons learned around that medicines infrastructure and apply it to innovative technology as well. We are engaging through the Department for International Trade, and also through Meddy Wells, through a range of different mechanisms, really, and just trying to kind of pull all of those lessons and sort of engagement structures together and focus those through the integrated innovation strategy. We know that the life sciences sector we know that the life sciences sector has grown significantly as a result of COVID, and we need to take advantage of that. So we are engaging on a number of different fronts, and all of that is being drawn into the development of the strategy.
Yeah, and I think we all recognise, and certainly in our industry we recognise, we've got a 20+ year history now with NICE and the guidance that comes through NICE, but built on a regulated industry with some very, very, clear ways through the MHRA and further on to make sure that the products that are developed are made available. So, anything that can be learned, I suppose, across into the technologies will be great, and probably we've done the difficult birthing of some of that work. So, if people can learn from it rather than reinventing the wheel, that would be great. Before I move on, Tom, and thank you again for all the time you've committed to this today, I just want to give a final call out if anybody does. I've noticed hands go up and down, people come on camera and go off camera. If there is any further questions, we've just got Tom. Before I move on to Gwyn's talk about the clinical access report that he's drafting on behalf of Welsh Government, I don't see anything, and Jonathan's not waving furiously at me, which I'm taking as a good sign at this point. So, Tom, lovely to have you back. As I say, people want to get in touch with you. Tom has shared some details in the chat function. I know Abby is very, very keen to keep people involved in the work that she's doing as well. Again, I'm sure she'd be happy. There's a mail-in address there for Abby and the work that her and her team are doing. So please feel free to make the most of that. At the ABPI, we've been banging on for nearly 20 years now about, the importance of having a single front door in Wales and how innovation and collaboration can only work if we do it together. So it's really good to see this, fundamentally different way of looking at things right the way across the piece coming to fruition. So thanks again, Tom. Hopefully you can join us for a bit longer, but I fully appreciate you've got other things. And I'm really pleased to see Gwyn up in my top left-hand corner. I'm not sure where he is on everybody else's screen, but it is lovely to see Gwyn here today. And Gwyn, you're going to talk about some work I think that you and Tom have been, Tom's asked you to do in updating a report that you've previously done. So can I hand over to you, and Priya, I'm sure, is in the background to help us all.
Absolutely, and thank you very much, Joe, and thank you very much, Tom, for that really interesting talk. I'm going to be driving my own slides, I think. So if you just give me a moment to try and share, and hopefully, if I get it right, which I should be by this time. There we go. Joe, could you just tell me whether you can see a MediWales slide? I
can indeed. Well done.
That's a thumbs up. Excellent. Right. So I have promised that this will take 5 minutes. So also I'm going to be as brief as possible and ask anybody who's got questions or input to definitely contact me, because that's really the purpose of this brief slot. So a little bit of background. So I represent MediWales. MediWales is the life science network for Wales. We're a particularly broad church. We represent about 200 members across medtech, pharma, biotech, increasingly digital companies, NHS and research involved in life sciences in Wales. So our day job is to bring together all of those elements and make the connections and make sure they can work together. Because one of the phrases you've already heard numerous times already today, is collaboration. And really, collaboration and innovation are the two keywords for our sector, as everybody in the room knows. So so it's a delightful job, and really love the people, the products, and the impact that we can have on people's lives in this sector. So yeah, going way back to the last crisis, pre-COVID, to the last crisis, the financial crash, and just after that, in 2010, Meddy Wells put together a report for Welsh Government at the time as well. And essentially the question was, how can we support, or the question we were being asked was, how can we support collaboration and innovation in health and social care? So the format of the report, it's a very simple exercise. It's not trying to create plans. It's not trying to create strategies. It's simply providing written evidence of key stakeholders, whether they be health or industry, key stakeholders, opinions, feedback, experiences of what opportunities and challenges there are to make things work better together. And so we're not trying to dictate, we're not trying to set an agenda, but what we did find when we did that report, that was that it created a really useful resource for teams like Abby and Tom and people in the NHS to just have an informed opinion when they need it to develop their strategies and plans. So the background is the NHS in Wales, NHS being the main healthcare provider by some considerable margin, is a tremendous powerhouse. It's a tremendous powerhouse of minds, innovative, intelligent, smart people. It's also it's spending a huge budget. So there is a lot of opportunity. There's opportunities to save money, and there's opportunities to invest. And it impacts on a lot of people. It impacts on virtually all of us, not to mention just the 78,000 staff. So it's a really good target there, and so it also has some of the biggest challenges, and that's probably due to the scale of the of what's trying to be achieved. So it's no secret that there are challenges in terms of working with the NHS, but there are also a huge amount of success stories and opportunities, and that's really what we want to understand. So industry, equally a fantastic sector. It ticks all the right buttons for economic development. It's over 360 companies in Wales. They tend to be high value companies. They tend to be smaller in terms of numbers of people, but tend to have very high value products, intellectual property led, and global in opportunity. Our companies across Wales are selling all over the world all the time. And only last week, with a lot of our leading people were in Dubai at Arab Health, pushing the Welsh, flying the Welsh flag, and I understand that was a real success. So it's diverse. It's pharmaceuticals, as Joe is the expert on and can tell you all about. But just to broaden the picture out, diagnostics, digital, medical devices, and biotech. With Wales does okay in all of those areas, and in some of them we really punch above our weight. So that usual benchmark, which is that Wales is 5% of UK GDP and population. There are places, there are areas of Welsh life science where we do better than that. But there is this opportunity to do even better, and there's a real focus on it, as Abby and Tom have been illustrating. So having a document that provides the evidence to inform that process can only really be good news. So we're going in with the assumption that collaboration in Wales is a strength. It doesn't matter which of those subsectors you're talking about. We're really good at talking to each other. Meetings like this one today are not to be taken for granted. They happen very they happen more easily in Wales than anywhere else in the UK. We're really good at engaging with each other. In a life science setting, in a healthcare setting, that's important for concept development, new products. It's important when we need clinical trials to provide the evidence so that we can comply with regulatory standards, but we also make sure that things are safe and that they work. And then evaluation, which is the NHS side of it, where Health Technology Wales are sitting in terms of making sure that products, processes, drugs are appropriate for the Welsh public and for the Welsh NHS. And then the one that's possibly the biggest challenge for us is procurement, and we've already heard that Abby's put that on her list for the innovation strategy, which is great news. So hopefully we can go through all of those phases and result in buying products. Buying products means that you can use them, so it's not just about making money for industry, it's also about improving patient care, reducing costs, and having that economic impact. So that's what we're trying to achieve. You'll notice that I've been very, very positive, and that really is the spirit I want to go into this this report with. It's not an opportunity to just moan, although if there are key challenges, key problems that organisations face in collaborating between industry and the NHS, collaborating between industry and academia and the NHS. We want to know about it, but we need evidence. We need examples. We're not just going to produce a paper that's having a moan. We're going to be very specific, and where we cite issues, problems, challenges, opportunities, we're going to use supporting evidence to back up those arguments. So that's the bit that we're going to do. What we need from you is your experiences, and we just need to collect that in any way possible. We will be having a number of roundtable workshops on the week commencing 14th of February. So if you'd like to join in with one of those, then please let us know. But otherwise, give us your evidence through writing, phone me up, maybe even face to face. Who knows? Things are going in the right direction. But the point is, that's my email address. I really want to hear from you, and we will collate this evidence and we will provide it back to Welsh Government and to the NHS so that they can use it and they can learn from it, and we can all collaborate and innovate better. So, Jo, how did I do on time?
You did great. Thanks, Gwyn. That's amazing. Can I just ask you to put all of the contact details in the chat as well? Because I appreciate we're going to move on in a second, and I don't want people not to be able to contact you.
Absolutely. Crumbs, I've got homework now.
Got any questions into the chat, or please do raise your hand if you'd like to ask Gwyn anything. I suppose the only thing from my perspective, Gwyn, and you'll appreciate I'm going to come from a very pharmaceutical basis here, and I know colleagues are on the line from right the way across the life sciences, and they're here from the NHS and into data and digital, which is a new world for both you and I know. But we'd be really interested in how can we collaborate further to make sure that from my perspective, our members have the right opportunities to engage in this. So is it just, shall we share some of your stuff with our members, or will you be reaching out proactively to people that are not already in your networks? How are you going to manage those sort of things?
Well, and we welcome hearing from anybody, and in respect to working with your members, I'm more than happy to work with you to make sure that works. I mean, all I would say is that back into 2010, medtech and pharmaceuticals were chalk and cheese in terms of their route to market and their access, and they've converged. Medtech has had to produce far more significant evidence of both efficacy and regulatory compliance, and so I'm sure there's a lot we can learn from you. So yeah, if I keep you in the loop, can we work on that?
That'd be fab. Yeah, no, we'll catch up out of this. But again, anybody who's on the line, if you're not part of one of Gwyn's networks already, MediWales is a new organisation to you and you have some thoughts on this, I mean, I'm sure we've got some really good examples amongst our membership of sometimes when it goes really, really well. I'm absolutely aware we've got some examples of when it doesn't go quite so well as well. But, you know, if we can do that, that would be fantastic. Gwyn, thank you for your time. We really appreciate it. And I'm going to move on, if that's okay with everybody, because I see that Dr. Aslam is on the line and has joined us. So thank you ever so much. Dr. Aslam is a consultant pathologist and clinical director up in Betsi, Cadwaladr. So we're delighted to have you join us today. And you're going to talk to us about IBEX and the SBRI and the world of digital pathology. So can I hand over to you if that's okay?
Thank you very much. It reminds me a few years ago, I came to the Life Sciences Hub physically to present our experience in Wales about digital pathology. And I think the time has come to move beyond digital pathology in the world of AI. Artificial intelligence, or what I say usually assisted intelligence, or augmenting intelligence. So what is our experience in Wales? The project started in DCU and obviously it's expanded to my colleagues in the South Wales as well. Next slide, please. So we started the project of using artificial intelligence in the prostatic pathology. And the question is that why? Because there are tools available in the other specialities as well, but we focused on the prostate. The issues were there are a few challenges in the prostatic pathology is specifically. First of all, we got multiple cores, which I will describe in the next few slides. So in each episode of specimen taking, multiple cores are being taken, usually per patient episode between 40 to 80 prostatic cores. And they are screened at variable magnification by the pathologist, consultant pathologist. There's a need of a screening and it takes a lot of a time. Because you are oscillating between the low magnification and the high magnifications, there is always a risk of missing tiny cancers. Other challenge we have is the diagnostic accuracy, because if you miss a tiny amount of cancer, the outcome is quite worse. And reproducibility as well, because the job of a pathologist does not stop as diagnosing cancers. Nowadays, it needs to be therapeutic markers to be identified. What will be the prognosis of that particular cancer? Because certain cancer with the certain grading are very indolent. And on the other hand, the certain cancers in the same setting with the high grade, with the worse outcome findings can behave badly. So the reproducibility of therapeutic markers is also very important. And if we do miss a diagnosis, the repeat biopsies is very painful procedure from the patient point of view, but at the same time is a big burden on the NHS as well, because if it's a high PSA and a negative biopsy and we have to repeat it, it creates a lot of harm to the financial side of the NHS and to the patient as well. Next slide, please. So what was the way forward? The way forward was to use the artificial intelligence to support the diagnostic accuracy in the prostatic diagnosis. So as I previously mentioned that I use the word augmenting intelligence or assisted intelligence because artificial intelligence is a little misnomer. Is actually this is the intelligence by the machine by deep learning, which supports the human intelligence to reach to a confident conclusion. The project started with the help of SBRI Outpatients Transformation Challenge. IBEX was successful to start a phase 1, which was based only in BCU at that moment of time, and have now recently awarded a 12-month developmental contract for phase 2, obviously funded by the Welsh government. In phase 2, apart from BCU, Swansea Bay and ABU health boards are also involved. And the project is using the Gywn platform, which is artificial intelligence tool, and it's used as an image viewing software to see and diagnose the cases, obviously with the support of SBRI Centre of Excellence. Next slide, please. So this is the state-of-the-art pathology department in North Wales, Betsi. We were used to see quite a lot of peacocks, but for some reason they are not there nowadays. Next slide, please. So what is the artificial intelligence solution available? It's quite tricky to explain in a small picture, but I will try to mention that it's basically its algorithm. The slides are made in a traditional methodologies, then they are scanned for our digital pathology at a times 40 magnification. Then the slides, the digital images, are read by the algorithm. The algorithm divides each image, each patient slide, a digital slide, into 3 categories. Very simple to the traffic light rules. So if it's green, it's benign. If it's red, it is malignant. And if it is amber, it's undetermined. Now, all these 3 categories will be seen by the human pathologist as well. So it's not that the AI has replaced the need for the pathologist input, but it has augmented their skills to identify even those lesions which are extremely tricky to identify in a normal routine reporting schedule. In the screen, you can see that there are multiple specimens which are starting with the H numbers. So this is the typical screen comes on the Gallon platform. You can see the first one is written 2 with a red mark, which means this patient has 2 slides and they are red, both are malignant. The second case is also 2 slides, 2 specimens, and both are malignant. Third one got 2 slides, but they are amber, which means they are undetermined and they need more pathological or even immunohistochemical input. And the next one got 3 green and 2 yellow, undetermined. So 3 benign and 2 yellow. And the next one is 3 amber, 1 cancer. That is the typical screen comes on the Gallon platform. And when I go into the first case, for example, in this case, in the details on the right side, there are 2 slides, both are malignant. Usually one will be the right side of the prostate and the other one will be the left side of the prostate. There's a peculiar system for prostatic pathology reporting in our system. Because it's a 3-tier system, we can actually triage. That is another outcome of the AI trial, that we can even as the secretaries or the lab scientists can see on the algorithm that these are the malignant cases, and if they need, they can be pushed bypassing the queue to be ready for the cancer multidisciplinary team meeting. Otherwise, every case will be seen by the consultants anyway. In our department so far, because we are okay from the manpower, we are actually not using this as a triage tool. We are looking all the cases at the same time because we got 6 pathologists who have an interest in prostatic pathology. And next slide, please. So what is the progress so far? The time I made this presentation, there were 246 patients whose biopsies were double reported using artificial intelligence and human pathologist. I think today, when I look on the Gywn platform, there are 262 cases already reported. Now, out of them, there is not a single cancer case which is identified by the tool as a malignant, and it's downgraded by a human pathologist. So all the cancer cases which are diagnosed as a red by the AI are validated and confirmed by the human beings as well, that they were malignant. So there is a debate about being a bit of a nearly 30% of the cases being put as undetermined amber, and some of them are gone into the malignant by the reporting pathologist, and some are classified as benign by the reporting pathologist. Now that data analysis is ongoing at this moment of time, and by the time we'll get the phase 2 results combining the entire Wales, that will possibly make up and some new threshold to identify that which numbers and what types of cancer probabilities in those amber cases turns always malignant, so that the tool can be modified according to our results. At the minute, 100% cancer probability index is considered by the machine as cancer, and those 100% cancer probability cases are always turned to be cancer as a second opinion as well. Now, as I mentioned in the beginning, the challenge we always have is the low power magnification and screening the entire tissue, and then switching to the high power if there are suspicious areas. In this situation, there's always a risk of missing tiny focus of cancer. So there is a significant reduction, if not 100% elimination, because we do not have a data at this moment of time to see that whether it's completely eliminated. And 100% elimination of any factor of any risk is very unlikely in medicine. But combining two together, AI supporting the human screening power, it actually significantly reduces the chance of missing any tiny tumor foci, because we have even identified one gland in all those prostatic cores being suspicious or malignant, and they are picked with the support of AI. It's also providing a lot of increased confidence among the pathologist and urologist about the technology and the diagnostic capabilities in the current medium of time. And precisely only last week, one of my colleagues attending the cancer multidisciplinary meeting, the urologist made a little joke about it, about a very difficult prostatic case, that what your robot is saying on this. So I think there is a lot of happiness and acceptance between different stakeholders on this one. The whole idea is to get it right first time. Rather than using as an audit tool, we want it to be done as soon as possible in a straight way in the first time correct diagnosis. We can use in future when we after doing the phase 2 trial across the Wales, I'm pretty sure that our prognostic markers like Gleason scoring, perineural invasion, high-grade PIN, which are very difficult and challenging and have subjective variabilities among the pathologists, we can develop more standardization across the country, where something diagnosed in North Wales will have the same language in the South, and because the patients do travel a lot in between. Next slide, please. So in this slide, I want to show how it looks like. So we can see that there's a hotspot area, which is identified by a red area by the AI, and that shows that this is malignant. And in the inset, we have removed the hotspot just to show in this picture how the cancer looks like in a without AI tool. So basically, the AI highlights the area, make it into different categories. In this situation, it's highlighted by a red area. You press the space bar and that red area is removed, and you can see the H&E typical morphology, and this is a high-grade cancer. Next slide, please. This is a benign area, and you can see there are three green dots there, and those three green dots are showing the point of interest. These point of interest, the Gywn platform identifies and push it to the pathologist that they are more important in this slide. Obviously, we screen the entire slide, and these three foci in a benign case, they indicate benign but atrophic small glands and a capillary in the center of the vision, which is highlighted in the inset. So that is a benign spectrum. On the other side, the first one was the malignant one. Next slide, please. Next, please. So the take-home message, which I think the conclusion of this presentation is that the entire process is heavily dependent on our robust IT support, and without IT support, it was not possible. It has done a lot of contribution and improving our patient flow, and I'm very sure that in the phase 2 and after phase 2, we will run this service across the Wales as a national tool. So I finished there. I think I'm just in time. Any questions, please?
Perfect timing, Dr. Aslam. That's amazing. Thank you very much. I love the assisting intelligence. I think that's a fantastic way of describing what AI can do in the healthcare setting. You're obviously moving into a phase now where you're looking at Wales, presumably the UK and then the world, but definitely Wales in the first instance. How are you working with Digital Health and Care Wales? Are you working with some of the new guys there on some of this work?
We have a digital pathology project going on from 2013, and in fact, digital pathology project itself is in a phase 3, and I think this month the paper will be with the chief executives to get funding from the Welsh government. But this is a separate piece of work which shows that beyond digital pathology, what can we achieve? Because digital pathology does not bring significant financial support, but what AI brings, not only financial side, it actually improves the patient pathway to that level that overall we can save a lot of money for the NHS. As I just mentioned, that if we miss one cancer, it costs fortune to the hospital, and plus obviously litigations for the harms and etc. etc. So that could be removed and it could bring. But without digital pathology, you can't have this. So I think it's the pathology is the AI in pathology is very successful and seems it will be very successful in coming days.
That's brilliant. Do we have any other questions, guys? I don't know. Everybody's being very quiet today, Dr. Aslam. I'm quite concerned about it. Oh, and then 2 hands go up almost simultaneously. John, yours just got there first, I think.
Oh, brilliant. Thanks, Joe. Dr. Aslam, I'm really keen to understand. So you talked earlier about you recently had a nice comment from one of your team about this program, and I think, as we all know, as we introduce some of these new ways of working, especially AI orientated projects, how those teams accept those projects. So especially clinicians with robust kind of ways of doing it. So how they welcome these types of digital solutions into their working day. So my question really is, how did your teams kind of welcome this project, and how did they get on with it to start off with?
Yeah. It's very interesting, actually, because when you start speaking about, oh, we are going to bring the AI, first reaction is a little bit of a negativity. Whether I will get my bread and butter tomorrow. That comes, that is it going to replace me? But my team, from pathologist team, who are using it for the last 3-4 months, I actually asked them that, what do you think if we don't have this now onward? Well, we'll resign and move somewhere else. So that is a transformation happens because people have realized it's so good to be true, that we can't live without it. So when I'm speaking with my colleagues in South, who are now part of this team, exactly the same ideology I gave it to them. At the minute they are feeling reluctant, but once they have used it, there is no way they can go back, because at the end of the day, we are all here to improve our patient workflow. And if I believe in my heart that this is actually improving our patient diagnosis to that level, whatever my belief is, that it will go away. And that is happening. So from clinician point of view, I actually had one debate ongoing with one of my dermatology colleague who had a very good interest in pathology, and he's having this dilemma about it. What is the liability goes? If something goes wrong, who is responsible? And I'm trying to convince that this is not artificial intelligence. You cannot compare it auto car driving on the road. It's probably, you can say it's an autopilot mode when you are parking. So still you are the one who is responsible to hold the steering wheel and watching the car maneuver reversing while going into the parking. So you are liable from DVLA point of view. It's assisted. It supports your skills, which you don't have otherwise. Well, I can spend at the times 40 magnification to report a prosthetic course, but that means I'll report one case in a day. But the machine does for me in a few seconds. And then it highlights those areas. So I screen at low magnification, then I go to the high magnification for those areas and complete my case. Previously, I was doing the same, but with the risk that I'm missing some information. And now I'm removing that risk. So it is very strongly assisting intelligence, which augments human intelligence.
I love that, Dr. Aslam. I've got to be honest, I've got one of those parking cars myself because I do not have the skills at parking. So, you know, the assisting stuff I think is brilliant, and you're obviously handling change management very well up there. Paul Williams, I can see you put your hand up next. I don't know if are you able to join us?
Yeah, absolutely. Just say hello to Mohammed again as well. I worked with him on the limb service recently, so I know Mohammed quite well and did lots of clinical forums with him and stuff. So hi, Mohammed.
Thank you.
Say hello again. So just a quick question really around innovation and optimizing healthcare. I know we did some stuff as part of the Link project with overseas in Australia, but just wondering if your thoughts on sort of learning from overseas sort of international collaboration where they've done sort of best practice. I think examples, things like, I know you're talking about cancers and particularly PET scans with nuclear medicine, things like that, but just on approaches to sort of innovation from overseas and within health economies overseas, really.
Yeah, a very valid question, Paul. And I think this is the way we are having a dilemma in the NHS actually, because we have to move on. We have to create some flexibility in our information governance rules, because that is a bit of a limitation factors. The technology is moving cloud-based, we know that. And the data, what we have received, we have attained from this study in Wales is the same data which is being achieved in France, in Israel, in other countries in the Middle East. And then collaboratively, we are coming the best data for our patients. So I think it's a global health economy now. So whatever we do, we have to work in partnership with so many different suppliers across the world, because a prostate cancer in Wales and a prostate cancer in India looks the same. So the technology will answer the same questions, but we need to come out of the boundaries of we can remove the patient names and biographics, etc. But the images science should be able to find a way out where we can share the information across the globe for the best interest of our patients.
And Zoe's asked in the chat, and I'm not sure if you're able to see that or not, but she's just asked if you have links in Cardiff and Vale, and I'm sure a quick thumbs up or, you know, that would be fine if you do.
Yes, I have as Paul mentioned, I have a few other hats on. I'm a chair for the SAG committee for the histology. So I work very collaboratively with all the health boards, pathology departments. So the colleagues in Cardiff and Wales, they are fully in pipeline. Unfortunately, they don't have a LIMS at this moment of time. As Paul mentioned, we are moving into the new LIMS, and hopefully in the next few months' time, and probably by 23, we will get a new LIMS installed first in Cardiff. And by the time our digital pathology national project also goes away into the right position. So everything together, I'm looking forward for a one cellular pathology across the Wales, having same services available to every patient. And I think that is our mission. And yes, I'm working very collaboratively with my colleagues in Cardiff as well.
That's brilliant. And Ravi, I'm going to take you as the last question, Paul. I apologise for that, but we have to move on to our next speaker. But Ravi, if you'd like to come on, lovely to see you.
No, nice to see you. And Dr. Mohammed, really nice analogy for the driving bit, by the way. Just quick couple of points, one question as well. So one is some of the work that we've been doing within Roche Diagnostics, where I work with NPIC, which is Leeds and those guys, reflects really well in terms of some of the things that you've identified in terms of the limbs and the, you know, the connectivity and all that. The one thing that, and maybe this is where the question is, the one thing that comes time and time again when it comes to implementation of digital pathology is very much around that change management piece and understanding what needs to happen within the pathology departments and the clinical departments, then coming together. And I don't necessarily think that's highlighted enough, because the focus tends to be getting implementational kits and equipment in, but not that change element piece. So just on that, I would love to have your reflection in terms of how do we make sure that the our colleagues within pathology and histopathology actually undertake that change management piece.
From it's quite interesting subject actually, because my experience for the last 5-6 years working very closely with the professionals in pathology in Wales, I think we are all on the same page. We run every month a national standardization meeting. We are all supportive. There are two challenges at this moment of time we are having. One is obviously the funding side, because as I said that our digital pathology project is with the chief executives. And hopefully by the end of this month, we'll get the approval and we get the phase 3 Welsh government support, and it will be implemented across. Second challenge is the IT. And I think my last slide was the IT. And that is a huge problem, because I'm sure you guys all know that we got tens of different applications in the healthcare system, and unfortunately they don't talk with each other. And this is a dilemma with the digital pathology. Like any other system, we do not want a standalone system. What we want, digital pathology linked with the limbs linked with the MDT coordinators. So you go to the MDTs, the results are available. That is linked with the WCP, so results are available. Everything speaks with everybody so that transcription errors do not happen. In my 25 years, 30 years experience in pathology, I've seen the most of the litigations actually comes from transcription. The patient's identity. A wrong patient case is being reported with a wrong slide because somewhere the data went wrong. So transcription errors are the commonest in health sciences. So that could be removed off. Regarding pathology colleagues, and I can tell very strongly with my heart on, we are all on the same page. We all want digital pathology to be in place with the support of AI to move forward, because AI has opened our vision. Previously, when we were starting, we were saying that we will spend more money on digital pathology. We need more resource, but the benefits were not coming a lot because AI was not there. Now, because AI is there, I think everybody's on board that this is the way forward. We need to move on. We can bring the triage systems. I have just seen the upper GI biopsy tool, which is fantastic. So you can scan the cases, and if there is a issue of the turnaround time in a lab, you can support the MDTs very quickly. I mentioned, sorry, I'll just take 1 minute. I know, Joe, you are looking to move to the next one. I got 6 pathologists in my department. If something happens tomorrow and 4 of them are off sick, like COVID happens, 2 of us can manage all the MDT services at least for 3-4 weeks, because we will put a triage, all the cancers will move on, and benign will stay for 4 weeks for my colleagues to come back. We can't dream of this, a few months back. So I think the technology is going into that direction. We need Welsh government support to fund the process. We need robust IT support in a national level. So I'll stop it there. I think I've taken a lot of your time.
Do you know what, Dr. Aslam, your enthusiasm is completely infectious. So thank you so much for giving us your time today. I'm sure if anybody's got any further questions, you'd be happy to take them offline. So I'm sure there's some contact details available through the Life Sciences Hub for that. So thank you again for today. And with massive apologies to Jamie from Kinsetsu, who we've kept waited in the background. Jamie, I hope you don't mind. I'm hoping you would taken along on that journey with the rest of us.
Yes, certainly no apologies needed. That was really interesting from Dr. Aslam. As someone who loves seeing technology being used in healthcare, it's amazing seeing it for something as emotional as cancer treatment. So that was really, really interesting. So I don't mind being a wee bit late.
That's perfect. And we've got a little bit of time at the end of the day, so we've got a little bit of flexibility. So please do give your presentation as you intended.
No problem. Priya, are you able to put the slides up? Brilliant. Thank you, Priya. So thanks, everybody. It's been really interesting so far today. As a technology company, we are always interested in talking about innovation, and especially in healthcare. So my name is Jamie Maginnis. I'm from a company called Kinsetsu. We're based over in Northern Ireland, as you can probably tell from the accent, but we have offices in Cardiff and actually in Australia as well. Kinsetsu is actually Japanese for proximity, and that's core to everything we do, understanding how close we are to things, understanding where assets of different types are. We describe ourselves as an IoT solutions provider, so an Internet of Things solutions provider. And really our ultimate goal is to try and use technology to fix problems, and especially fix problems in healthcare. My role, as you can see here, is Chief Experience Officer. And it's a bit of a new sort of job title, that, but it's something that has moved into the world of technology recently, where traditionally when we were providing solutions or projects, it would all be around delivering them on time, you know, and to budget, but there maybe wasn't enough thought about the overall experience. So myself and my team, that's what we're focused on. We're focused on working with customers, really understanding at events like this what the customer's need is, what's happening within the industry, and then making sure our solution delivers and fixes problems that are happening within the industry that we're working in. So next slide, please. So we do work across different verticals, both in health and education and commercial businesses. So really anywhere that we can put our solutions, but most of our focus is on healthcare and has been since the business was founded. And most of that focus has actually been within the Wales NHS, and I'll talk about the customers that we are working with there at the minute. So what we do essentially is we understand that healthcare organisations are continually challenged to find better ways to manage processes, with them being pushed to their limits all the time, and nothing more than over the last couple of years with COVID, where we realised that everybody is under a massive amount of pressure. So what we've hopefully been able to do is use solutions to try and ease some of that pressure. So we use IoT-enabled sensors, whether that be RFID or Bluetooth, and our bespoke software to locate assets for clinicians. So the main thing for us is around giving back time to staff in hospitals so that they can do what they want to do, and that's focus on the treatment of patients. The technology delivers automation, integration, data-driven outcomes, and improved safety. And the assets become discoverable. So when we're talking about assets, that can be anything from a medical record to a wheelchair to a bed, a pump, any asset we can track. And that can be tracked within a hospital or out in the community. And I'll talk about that in a wee minute. So as I said before, ultimately what we want to do is unburden healthcare professionals and give unprecedented levels of confidence, traceability and cost savings and time efficiencies. And that's all about allowing staff to focus on patients. So next slide, please. So we actually have a core product called K-Track, which you can see on the screen here, and this is quite a mature product that we have in several hospitals throughout the UK, both in England, in Wales, and over here in Northern Ireland. And this product, as I said, is quite mature, and the focus on this is being able to track medical equipment. So what we do is we use RFID technology, and we tag medical devices, and again, that can be any device from a small thermometer to a bed to a wound evacuation pump. Any device can be tracked, and we use RFID for that, where we work with the customer to deploy RFID readers around the hospital, and then as those medical devices move around the hospital, they can be seen in different locations in real time. So as you can see in the example that we've got here on the screen, we can very quickly, and the hospital can look at this in real time, and they can see in the main building there, they've got 97 assets. What they can do is click on that, and it will show them exactly what assets they are, how long they've been there, and the status of those assets. We can also track, it's not shown on this screen, but we can also track out in the community. So as technology has moved on, sort of 4 or 5 years ago, trying to track a device out in the community was quite difficult. With technology now, we can do that, and we can use GPS, we can use mobile data, and we can actually attach sensors to devices that we know are going to be sent home with patients, and we can then work out exactly where they are, and that can be displayed in our K-Track software. So as I say, K-Track is our core software, but we are a company that likes to be we're hardware agnostic, so we like to use different sensors and technologies and bring them into our platform. So when we talk to hospitals, our first question is really, what are the problems you're having? So K-Track will solve quite a lot of problems because we know they exist, and we've got the software out there, but we also know that problems are always changing. There's new issues and problems coming, and what we want to do is use IoT, use technology to try and fix those solutions. So we always try and start at the end with the problem and work the way back to the technology. So if we can see the next slide. And really, this is just zooming in, so we can zoom in using K-Track, and you can start to see more details around what is in individual rooms within buildings. K-Track is GS1 approved software, so I'm sure that will mean quite a lot to people who are working, around scan for safety. So we can store GS1 GIAI numbers and GLN numbers to help with hospitals' journey around scan for safety. So next slide, please. And sorry, those previous 2 slides have shown you are obviously screenshots. If anybody's ever interested in seeing a demo of our product or seeing it in more details, we can certainly do that. You'll have my details from this. You can just drop me a message, and we can organize a demo to show you the functions. So some of the use cases that we have, and specifically in Wales NHS, so we work with Cymdeithasol and Hywel at the minute, and both those health boards, we are tracking medical devices. We're also tracking, recently we've started a project around tracking oxygen and other medical gas cylinders, and that allows we took our core product K-Track and we stripped it back to make it really easy for porters to create the medical gases as assets in our system, with them doing very little work, and it associates an RFID tag with the gas cylinder, and then very easily that can be tracked around the hospital, both using fixed readers and handheld RFID readers. So it allows porters to walk into a room where they know there maybe is 5 or 6 gas cylinders, and using RFID pinpoint whereabouts they are in the room without having to go around and look behind curtains or under beds, because we'll be able to scan those using the RFID readers. For other medical devices, it's things like wound evacuation pumps, BPAP, CPAP, beds, mattresses, McKinley pumps, wound evacuation pumps, And it's a similar sort of solution we use for those where we create those assets in our system, and we can integrate with asset systems that hospitals are already using, like RAMS or Equip or any of those asset solutions. We can pull the asset information over onto our onto our software, and then create those assets, so that it makes it really easy for the hospitals to start tracking the assets around their hospitals. We've also done quite a bit of work around COVID-19 contact association. Hopefully it's something that's going to be less needed going forward, but we worked with the Belfast Trust here in Northern Ireland to track assets going out in the community, going into people's houses, and they were able to flag those assets as COVID-19, and that meant that they were, you know, collected and managed in a different way to minimize the risk of any sort of infection being passed on. We also are working with things like drug bags and special specimens to try and make sure that what's meant to be in a drug bag is in that bag, and it's at the right place at the right time. And again, because we're using RFID technology, it really takes away the likelihood of human error, because you're scanning these devices and these assets, and they can only be seen if they're actually there. So, you know, someone looking in a bag can make a mistake. The technology stops that from happening. And some of the key things about our product is that it's one platform. So we do lots of things outside of healthcare use cases, things like air quality monitoring, people counting, and we display that all in one place. So we can take that for a hospital, and if a hospital wants to do something like manage the temperature of their fridges, we can do that. We can manage the temperature, and we can display that on K-Track. So it makes it really easy for them when they want to go in and look and see what the temperature of the fridges are, if they want to know how many people are in a certain location, or if they want to know where their assets are, they can do that. As I said, we have APIs to existing systems. The data, all the data in our solution is easily exportable. So if for whatever reason an API isn't used, we can easily get the data pulled off in CSV file and used somewhere else. So some of the stuff that we've touched on there today is around, everything we do is around using data to make life easier. So driving efficiency, ensuring compliance, improving safety, lowering operational risk, and ultimately it's about releasing the staff time. And I think that is it. Yeah, so we've just got a couple of our customers. Rob Salter, who some of you may know, who was in Royal Glamorgan Hospital, and also Paul Duffy, who's the co-director of ICT in Belfast Trust. There's a few wee comments from them.
To hear from you. Thanks for joining us, Mike.
All right. Yeah, can you see the slide okay there?
Absolutely. Yeah, brilliant.
Great. Okay. So yeah, hi everyone. My name is Mike Wilson, and I'm the healthcare market researcher for Life Sciences Hub Wales. And part of my job as a researcher revolves around horizon scanning, assessing and analysing emerging trends and technologies in the healthcare sector. So when John came to me asking if I could present a short piece about horizon scanning and patient access, one technology that came to my mind was mHealth. That this is the use of mobile technology in the delivery of health services and data collection, especially in this age of COVID, where so many services have seen this rapid adjustment to being delivered remotely. mHealth has kind of come into its own as being a means of using our mobile devices to deliver healthcare in more convenient and accessible ways. So I'm going to be talking today about a little bit about mHealth apps, their use, and to give a few recent examples of their application in healthcare. So what exactly is mHealth? Well, as I mentioned before, it is the use of mobile technology in the delivery of medical services. This primarily refers to mobile phones, but also includes other mobile devices, tablets, laptops, even personal digital assistants and other wireless infrastructure. Though for the purposes of this talk, I'm primarily looking at mobile phone apps, as these are the devices that are most widely accessible by users and providers of healthcare. So the capabilities of mHealth has seen some remarkable advancement in recent years. Developments in processing power, in artificial intelligence, cloud computing, the miniaturization of technology, allowing for wearable tech, wireless communication, Bluetooth, 4G, 5G, all of these advancements means that the applications of mHealth are far more wide-ranging than they ever used to be, and means that mHealth is likely to become far more prevalent in the future. So I've listed here a number of applications of mHealth, and these range from providing health information to collecting health data for monitoring and diagnosis, and enabling telemedicine as well. The image on the left of this slide, which advertises a service I'll be talking about a little bit later, echoes a major theme in the application of mHealth, and a major sentiment that makes mHealth so appealing, in that it improves patient accessibility by bringing services to the patient rather than it being the other way around, and that those services are just as effective, if not more so, than traditional methods. And this is the big appeal of what mHealth offers. So looking at mHealth apps that are available, these can be split into three main categories. The first are the health and fitness apps. These are the largest category of apps, and they often rely on user input and often catered towards self-improvement. So these are your dieting apps, fitness trackers, mindfulness apps, things like that. The second category are diagnostic apps. These often rely on collecting data using an external device or sensor, which is often used in tandem with an accompanying mobile phone app. That data is collected, stored in the app, and is then relayed to healthcare professionals for interpretation. Or increasingly, data can be analysed and interpreted by an artificial intelligence. Category 3 are the information administration and organisation apps. These revolve around storage and accessing of patient records, as well as things like arranging clinician appointments or even capabilities of telemedicine via video chat, voice call or online messaging. So we'll go through these in a little bit more detail here. So the health and fitness apps are by far the largest and most popular category. There were estimated to be over 350,000 different health and fitness apps as of 2020. These are relatively easy to put together, as they largely rely on user input, so people tracking their progress over time. And the app will often offer tips and recommendations. However, the big problem with health and fitness apps is this dependence on user input, which can make the data unreliable. Primarily, the issue seems to be user adherence. So people download the app, they'll input their data for a week or two, and then they'll stop using it. So a major challenge for this category of app is providing that motivation and incentive to keep using it. So as a result of this patchy data, the clinical evidence for their usefulness is quite limited. So whilst they may be the largest category of mHealth app, clinically they are perhaps the least relevant at the moment. The diagnostic testing apps are often much more technologically advanced and will cater towards monitoring or analysing a single metric. So rather than relying on user inputs, data is collected by an external monitor, which will communicate wirelessly with a mobile device. So applications include monitoring of heart rates, blood pressure, blood sugar levels. In fact, one example device that I wanted to talk about was for glucose monitoring. So this device by Dexcom is the G6 glucose monitoring system. It consists of 3 key parts. So there's the sensor wire, a transmitter, and a display device. The display device can either be the Dexcom's own receiver or an app that can be used on a compatible smart device. The sensor comprises a water-resistant sensor pod that is worn on the skin, and the sensor wire that is inserted under the skin using an applicator. The sensor can be worn for 10 days and continuously measures glucose levels. During normal use, interstitial glucose concentration estimates are sent from the transmitter to the receiving device at 5-minute intervals and can be checked at any time. Alerts can then be set to respond when glucose levels or rates of change go outside the healthy range. The user can choose to share glucose levels, trend information and alerts with others, such as carers or family members who can view the data in an accompanying app. And this device was actually assessed by NICE in November 2020 in a MedTech innovation briefing. In that briefing, expert comments on the device stated that they considered it was innovative and that it could help prevent the need for clinical intervention. It could also help to reduce costs and benefit the healthcare system. Another device in the category of diagnostic apps is the Butterfly IQ Plus. This is a pocket-sized portable ultrasound scanner which connects to a clinician's smartphone. It is marketed as the world's first handheld single probe point of care whole body ultrasound scanner. Images can be displayed on the connected devices and can be stored and shared with others. Again, this had been assessed by NICE. This was in March 2021, and expert comments on this device said that it could improve diagnostic accuracy and support rapid diagnostics, as the ultrasound could be used immediately at a patient's bedside. It can increase accessibility to ultrasounds because of its portability and connectivity. It could improve outcomes and reduce hospital visits, as it's can be used at the point of care and can lead to system benefits by allowing clinicians to share images. So this is just a couple of examples of how mHealth can be used in health monitoring and diagnostics, and there are many more. As the technology improves, so too does the capability of these kinds of devices. Moving on to the third category of app, the medical information apps. These range in functions around information management, access, and healthcare administration. They can allow the physicians remote access to patient records and allow patients access to their own data, as well as access to remote services. One of the primary apps in this category is the eConsult app, the use of which has rapidly expanded as GPs began offering more services remotely in the wake of the COVID-19 pandemic. So eConsult is the NHS's leading online consultation provider, having been started in 2013 by 4 GP partners in the Hurley Group in southeast London. It's currently implemented in over 3,200 GP practices. It may be something that you've used yourself. The application allows for patients to submit their symptoms or requests to their own GP electronically and includes NHS self-help information, signposting, and a symptom checker as well. It allows for video consultations and chat functions, as well as the convenience of being able to contact clinicians remotely. A key advantage of the app is the availability of information and support whenever it is needed, 24 hours a day, 7 days a week, evenings, weekends, and holidays as well. Another app with similar capabilities is the Babylon Health app, which offers online consultation services. The app is being trialled in London by NHS Hammersmith and Fulham as GP at Hand. This is the service that was being promoted as Let Your GP Come to You, which was the image you saw at the beginning of the presentation. Specifically, the trial was designed to benefit people who have episodic, well-defined needs, are digitally confident, and find it difficult to access services near to where they live. The 4 main applications of the system includes a symptom checker. So this asks questions about symptoms and then uses artificial intelligence to determine possible causes and next steps. It includes it includes online consultations. So video appointments are available 24/7. They can be available as little as 2 hours after booking. Electronic prescriptions can be sent to local pharmacies for collection, and it provides access to clinical records, health information and history as well. There's a health check application, which is an information portal offering practical insights to stay healthy. And there's a monitor application as well, which allows users to import and store data from activity trackers. So calling back that advertising campaign of let your GP come to you, mHealth is all about improving patient access by bringing the services to them. And as technology improves, this capability is getting greater and greater. One quick final note on equality of access, and this represents one major barrier really to mHealth apps, and this is that a lot of the benefits of mHealth rely on access to and confidence with smartphones and mobile technology. So this graph on the left shows that the proportion of people at different ages who regularly use smartphones, and you can see that as age increases, the sort of usage of smartphones goes down. So mHealth may promise a lot of things, but it can be difficult to access for older people. And accessibility to these services is also important, considering people with disabilities. It's really important to consider these audiences when choosing to adopt a mobile health technology. You know, are these systems in place, or rather, are there systems in place to help these audiences use these services, and what more can be done to make access to mHealth more equal? So that's sort of one point that's you can consider as I close off my talk. But with that, yes, thank you for listening. I'm happy to take any questions or any comments. My email address is there at the bottom of the screen, so if you want to contact me, I can address any comments. So thank you.
Mike, thank you. That was an absolute whistle stop tour, and congratulations in getting all that information in. And I can see your colleague Jonathan has put something in the chat, and I presume, Jonathan, this is going back to your previous life in physiotherapy, but sort of talking about how it could really, some of these apps can really help benefit professionals going out into the community, and obviously keeping care closer to home. Is that something that we see a lot of? Is this move towards a home care environment?
Sorry, was that a question for Jonathan?
Yeah.
Sorry, Joe. Yeah, absolutely. I think, you know, especially the Butterfly IQ, where, you know, we are seeing advanced practitioners working with, you know, newly developed imaging skills, and a lot of those practitioners are being kind of shipped out into primary care or you know, services which are closer to patients, and just giving access to those kind of those capabilities within those kind of more remote settings is quite exciting, and you know, and all of which should be of benefit to the patient and in adding value to the outcomes of that intervention. So yeah, it's just really good to see some of those examples, Mike, and yeah, looking forward to the next meetings kind of insight that you can give us. So yeah, thank you very much.
No, that's brilliant. Thanks, Mike. And again, anything that we can add to the chat, Priya or Mike, about contact details for people who might want to follow up after this, that would be great. Jamie, I'm hoping I've got, brilliant, I've just seen Jamie come on camera. This is always one of those reassuring moments. And I think you're going to talk to us about some of the work that Hafod and Accenture have been doing.
I am indeed, yeah.
Brilliant. Can I pass over to you?
You can, yeah. I'm just going to attempt to share my screen. Everybody able to see that? Do you see the slides there, Joe?
Yeah, that's great. Yeah. Thanks, Jamie. Brilliant.
I can't see anybody else, so I just assume that everybody can see me, and that's fine. Yeah, I know some colleagues here, but just to briefly introduce myself and my role, I work partly for Hafod as Director of Innovation, working on matters around social care, housing and integration, and partly in Side by Side, which is a kind of like a fringe movement, I suppose, set up by Hafod to pursue social innovation It's been in existence for about a year, and we work on sort of long-standing social economic problems where solutions would have a really high value to society. But I'm really pleased today to speak about this specific piece of work on the role of tech in mitigating loneliness, and it builds really nicely on Mike's presentation, I think, in the context of access and decision making, where I think it definitely has a story to tell. And it's been quite a journey, this one, so I'll struggle to sort of shoehorn it into 20 minutes, but I'll do my very best to make some sense. So just to start with a little bit of context on loneliness and isolation as an innovation challenge, it really, exploded onto the public arena, I suppose, during lockdown 1. But we've got a longer history with it. So in the communities that we work in, we often deal with the consequences of chronic loneliness, and it's often the underlying cause of something else that will manifest itself in a crisis. So when older people enter the system having been chronically lonely, their likelihood of exiting the system with a good outcome is greatly reduced. And as the evidence on the slide here tells us, being lonely comes with elevated risks for heart disease, strokes, and dementia, amongst other things. And these links are causal, they're not just correlations. And it's been estimated that the overall net effect of loneliness on life expectancy is equivalent to something like smoking 15 cigarettes per day. So it has got a really strong and bold health signature, being lonely. And for older people, through the pandemic, those risks have been amplified, risks that were already there, particularly around digital exclusion. And although the biggest growth in digital take-up was amongst older people, reflecting that sort of coping mechanism that access to the internet has become for people, older people already at the margins or excluded were just further excluded from society, really compounding that loneliness and isolation for them. So the problem that we've been trying to solve around loneliness is, how do we deliver low-level intervention that can protect people from the worst impacts, and try and do that in a scalable and sustainable way? Because we know loneliness responds well to intervention, but our services just can't be everywhere at once and in people's lives enough to see the early signs. And that was a challenge that we were working on pre-COVID, but it obviously became all the more pertinent when we entered that lockdown state, and we just couldn't deliver the face-to-face services the way we normally would. So we were already working on the assumption that tech was part of the solution for us, and that's where this idea and this alliance really grew from. So just moving on to talk a little bit about that alliance, that's really important to the way we work. So just to say a little bit about its origins, really, which were about 2.5 years ago, when I know Gwyn was representing the interest of the Life Sciences Hub, and Jonathan was involved, and we have just sort of coalesced with the Hub, with Swansea University and with Accenture, organisations with very different but overlapping interests in loneliness and in innovation. And cut a long story short, we worked up a proposal for testing and refining this emerging technology that Accenture had created, aimed specifically at supporting people who are lonely and isolated, and with some really early positive signs from just really rudimentary pilots with Age UK and others. I hesitate to say it was the first of its kind in the world, but there weren't many sort of comparators out there at the time, and there still aren't really. We tried to identify funding, take that early solution forward, but the world wasn't quite ready for it at the time. And it was only a month before COVID landed on our shores. And I always wonder whether the people who turned us down might have felt differently if we presented to them a month later. But, from there, that sort of consortium, it morphed into a second iteration where the Life Sciences Hub bowed out, and we continued to be a sort of 3-part industry academic delivery partnership with a trial involving Hafod customers through the first half of 2021. So it's a pretty unique alliance. I could spend a lot more time unpacking that, but what I've also tried to indicate on the slide here is that bigger ecosystem that this innovation sits within. These are all organisations that have touched this solution and this venture in some way, and will probably continue to do so as we move ahead. So what is this thing that I've only talked about in a very abstract way so far? It's called home care. It's essentially a smart home companion powered by really hyper-personalised conversational AI. It's all voice controlled. Accenture's got patent protection over that aspect of it because it really is quite unique, and it's the main technical innovation here. It's got a really extensive history of co-production and co-creation with user groups of older people in various different settings, different contexts. But the current iteration, the current prototype, if you like, was shaped during lockdown 1, using feedback from welfare calls that we at Hafod made to around 1,500 of our customers who are living alone and therefore at risk of loneliness and isolation, if not already. And they told us some really surprising things, but the things that they told us were difficult for them or causing them concern or pain, they were sort of encompassed in the design of the prototype that we already had, and so was born home care as we know it now. So,
Jamie, can I just stop you? We're having a couple of problems with the slides, so they're not moving on. So I just wondered if you wanted to see. Sorry to interrupt you.
That's fine. You should be on solutions and origins.
Yeah, I'm still on your first slide, and I think it's the same for others as well.
Ah.
Priya, I'm going to look to you now as my helper in all things technical.
I'm happy to step in for you, Jamie, if you just wanted me to push the slides along for you.
Thank you. Yeah, I shared the window rather than the screen or the PowerPoint live, so it usually works.
No problem. I will share the slides for you. Just let me know when you're ready to move along to the next slide.
Brilliant. And I think we're going to share them after the meeting as well, aren't we, for people, so they get the really good chance to catch up as well. There we go. Thanks, Priya.
Yeah, thanks for letting me know, Joe. Yeah, so I was talking about just about to talk about the functionality, and I'm glad we got those images because they are real images of that sort of co-creation, co-production that I talked about. So in a nutshell, home care, it helps people make and maintain meaningful connections that protect them against the worst effects of loneliness. So it does things like it monitors mood and well-being and analyzes trends on a day-to-day basis. It creates and manages appointments in a voice-controlled sort of format. It performs home security checks, which is something that people living alone seem to value really highly. It helps people manage food supplies and connect to food banks, as well as supporting video conferencing just to keep those really important connections going for people. But one of the unique features is this facility for really data-driven two-way communication with, say, a carer or a support worker, or in our case, a neighbourhood coach, which is really key to delivering these low-level interventions I talked about, the things that help us mitigate those worst impacts. I'll say a little bit more about that in a moment. The solution is completely agnostic as far as platforms go, meaning there's loads of opportunity to integrate with just about any existing product or platform that's already out there. But we've opted for now for Alexa and Amazon's Echo Show device for the trials that we're conducting, purely based on affordability and functionality, and the fact it's just a really malleable sort of format to work with. And I've tried to summarize the benefits here that it's intended to deliver at different levels, from the individual through to the system level. I don't really need to read through all of that, but the basic premise is it's a pyramid of outcomes, really, the logic being that preventing negative things happening for individuals at sufficient scale will, in the long term, reduce net demand on health and care services, where loneliness actually drives quite a lot of excess demand at the moment because of this path dependency that leads on to higher levels of need for care and support. That's a big claim to make, I'm aware of that, and it's a very difficult one to evidence, a difficult one to prove, but that's the basic theory of change here. Could I have the next slide, please, Priya? Thanks. So just in terms of accessibility and decision making, sort of things pertinent to the theme of today's network. One of the things our coaches and customers seem to value most is this two-way exchange through home care's portal. So as well as being able to just converse in a really quick and easy way with your neighbourhood coach, support worker, carer. For example, data on well-being and mood can be really easily shared across the portal in real time. So we've got a handle on this real-time data, this trend of how people are feeling over any period of time that we have data for. And any kind of anomaly can be flagged to the relevant service. So this is crucial because it gives us that early insight that can prevent something from going wrong or prevent an emerging situation from getting worse and escalating. It gives us a real-time decision-making tool that we can use to really good effect. So, as such, home care allows us to replicate bits that are good about a really person-intensive face-to-face service. But of course, the intention is never to replace that. It's to supplement it, and it's to make it more scalable. It's definitely not the role of technology, we feel, to replace a neighbourhood coach. But for customers, it gives a much quicker, easier access to a neighbourhood coach or a support worker that they might otherwise have to access through more traditional, more laborious kind of channels that feel more formal, actually feel quite hostile to some older people and really difficult to navigate. So I think home care is addressing a really crucial access barrier in this respect. And the threshold of digital skills that are needed to use the solution successfully is set really low, which addresses one of the really significant barriers to access, actually. So in all honesty, we're only just beginning to understand the long-term impact of that, but the early signs are really positive ones. And I'd say the same about our resources and how this early insight helps with our ability to deploy resources more strategically. I'm sure that's going to become much clearer with time and a larger scale rollout with a lot more opportunities to learn, but it's early days yet. Can I have the final slide, please? Thank you very much. So just briefly, really, to round off and talk about the next stages in this innovation. Basically, we need a larger scale rollout with lots more opportunities to learn, preferably with thousands of users this time rather than the 50 or so that have been involved in the initial trial. We are well aware that the solution we developed it's been well received. We've had good feedback. The evaluation data we've got is strong, and there appear to be benefits at that individual level to users. But that's not quite good enough. There's also a lot we don't know. And there's a lot of, within that evaluation data, a lot of feedback to work through where users have told us what they'd actually like it to do, what functions they'd like it to support, how they'd like to interact with it, how they'd really like it to understand a Valley's accent when it doesn't, for example. So as an initial next stage, I think we need a design gate, a period of really intense co-production with a large number of users, whether that's those without English as a first language, those with cognitive impairment, people in different kinds of circumstances, right across the spectrum of loneliness, to see if and how it can help. Because I think we've designed for an average and we haven't yet touched the extremes. Then I think we need this more ambitious large-scale rollout. And in fact, we've been interviewed for a Innovate UK Design for Ageing grant, which would actually support that larger rollout. We're waiting on the outcome of that at the moment. That would help us contain the costs for the users. It would subsidise their subscription costs to make it really affordable, allowing us to realise the economies of scale and bring our costs down to that level in the long term. So that's the catalyst this needs now. And I think some public money to share the risks and rewards feels like the right thing for us now, as both Accenture, my organisation, have invested quite heavily in financial terms and in kind to sort of get it to where it is now. So we feel like it's time for the public to share that risk, because that's where the rewards are going to be felt the most. What we think we'll learn from this is that there's a lot more to know about the patterns of loneliness and where the needs are most intense, which in turn will then guide our resource deployment and how we intervene and to what extent. None of this addresses need that's still hidden. So the more we can embed technology like this in how we actually deliver services by default, the more likely we are to uncover these hidden needs and be able to break that cycle in more people early enough. And of course, we're going to learn a lot about barriers to digital access and digital skills, which, you know, we're doing our best to overcome at the moment, but some of those are structural, some of those are not strictly our problems to solve. And that's probably the subject of a whole other discussion. But for now, we've simply had to subsidise internet connections and device costs for people just to get the trial off the ground. So we expect that to be the same when we attempt any kind of wider deployment. So, you know, that's a real brief introduction to the innovation, where it came from, you know, where it's at now and where it's going next, sort of in this context of access and decision making. I hope it was interesting. If you've got questions, I'd love to answer them. Thanks for listening. Thanks for your time.
Jamie, that was fantastic and really informative. It's fascinating to me, as somebody who's been so focused in healthcare for a long time, that people are looking at these sort of spaces in between and making sure, because this is going to have such a huge impact for colleagues right across the healthcare system. But it will also have impacts for housing associations. It'll have impacts, you know, for social care right the way across. I can see that Amanda, one of our colleagues from Powys, is asking you for your contact details. So I hope that's a really positive sign that she wants to continue the conversation with you too. And we will be sharing your slides afterwards. And I know you'd be delighted to sort of have these ongoing conversations. And as Jonathan has said in the chat, you know, fingers crossed for that UKRI funding, because it really is, you know, a great opportunity.
Indeed, yeah. We'll know soon and we'll let you know.
Brilliant. Looking forward to it. I'm not seeing any other questions. So thank you again, Jamie, and thanks for taking part with that today. And have I got Ruth on camera? I'm making a huge yes. I can see Ruth's name now that's come up underneath the picture. Hi, Ruth. It's lovely to meet you and welcome this afternoon. So you're going to talk to us about CEDARS and all the exciting work that's going on with what you're doing. Are you okay with your slides, or would you like Priya to share?
I think Priya's going to put it up for me.
Perfect. I will leave that in Priya's capable hands then. Thank you ever so much.
Thank you. So yeah, just to introduce myself, first of all, I'm Ruth Poole and I'm working with CEDARS. Some of you might recognise me from my days working for Health Technology Wales. And I think 10 years ago, I might have met Joe when I was working for the British Dental Association. So it's a small world, South Wales and health and care research. So it's lovely to see people again. And thank you for giving me this opportunity to share what we're doing. This is just one part of CEDARS' work. There's much that I will not be covering today, and it will only be a very short presentation, so you'll be pleased to hear that you should get out on time. So this is just introducing an application that we're currently making. So we're in the middle of a funding application to the NIHR Health and Social Care Delivery Research Programme. And the title of our proposed team is Cardiff Rapid Evaluation for Service Transformation. So we have CREST as our acronym. So first slide, just to introduce what I'm going to go over. There we go. So yeah, I'm just going to introduce what the team is intended to achieve, how we've put it all together, how it fits in with the innovation network and how you might be able to get involved with what we're doing, and what the kind of next steps are with our application. So can I have the next slide, please? So as I said, it's the NIHR Health and Social Care Delivery Research Programme, which has quite a broad remit. The focus is on how care is delivered or organised rather than effectiveness of treatments on individuals. And it's looking at evidence that will be of major and sustained strategic importance to the NHS and social care. It's likely that our team will focus on the NHS side of it rather than the social care side of it, but there may well be some projects that cross over. And so there are already 2 teams that are doing this work for NIHR. So there's the Rapid Service Evaluation team, which is based in London but working with the Nuffield Trust and RAND. And then there's the team at Birmingham University, also working with RAND and Cambridge. So they're called BRACE. So those teams have already been running for a few years, carrying out evaluations for NIHR, but NIHR are now looking for a 3rd team to join in and contribute towards the programme. So this is for a 5-year contract, so it would be quite a big piece of work for us in CEDA, but really exciting. We've already been moving into this type of evaluation work already, so we'd really love to build on that. So yeah, some of the aims of HSDR are to evaluate innovations and developments in health and care services, and there's a particular emphasis on doing the evaluation in partnership with frontline health and care services. So the people on the ground who know exactly what's going on and what the challenges are. So one of the things that we are excited about is that there might be opportunities for us to identify innovations that could be transferable throughout the UK. So it's potentially another way that we can put Wales on the map. And the aim is to generate evidence that will be of immediate use to decision makers. So, you know, it's called rapid evaluation for a reason. They definitely want this to actually have kind of to be actionable in the real world. And overall, the aims are to improve the quality, effectiveness and accessibility of NHS services. Next slide, please. So the core team, in CEDA, we have a team already of around about 20 people. It's growing at the moment, so it's a bit difficult to count everybody. But we are mostly researchers of various different backgrounds, and we have a wide range of skills amongst us. We are led by Dr. Rhys Morris, so he is one of the joint lead applicants on this application. So CEDA is largely based in Cardiff and Vale University Health Board. We also have some staff that are employed by Cardiff University, so we're part of Cardiff University as well as Cardiff and Vale, but we're really embedded within the NHS, which I think is a real strong point for our team getting involved with this. As I said, we have got some experience of carrying out mixed methods evaluations of service delivery, and we also have a lot of experience with project management of this type of work, and we've got a lot of research skills within the team, but there are some specific areas where we felt we could benefit from bringing in others. So it's a broader team than just CEDA, and we've been really fortunate to get the support of Professor Davina Allen from Cardiff University. She's the head of research and innovation in the School of Healthcare Sciences. She's a medical sociologist and nurse academic with an international profile in research in the care workforce, service organisation and delivery and improvement. So she's going to be a real bonus to helping us achieve this. We've also managed to get on board some others individuals who are specialists in co-production and in development of new evaluation methods, and then there are other members of the team. So we'll have some public and patient representatives, We have someone from Health Board Innovation and Improvement. We have got an independent statistician, and we're hoping, we still haven't confirmed a knowledge mobilisation expert yet, but we're working on that one. So that's so that we can kind of help develop approaches to getting fast uptake of research findings in the NHS. Next slide, please. So how we would like to link with the Innovation Network. We really just want to, I mean, this is just an introduction, but if we get through to the next round, we'd really, really like to engage with anybody out there who might want to be involved with this work. NIHR really want us to be working closely with evidence users who are innovating in health and care services, which is why I'm here, because that's exactly what you do. And for the different projects, we'll need experts in various different health service delivery and organisational disciplines. And there are a few different roles that you might fulfil. So we'll have a programme advisory board that's in place throughout the 5 years, overseeing general work that we're doing. But then for each individual evaluation project, we will need content experts. And we can't really say in advance what those are going to be. It will depend on the actual specific topics that we're working on. And then also, you know, there may be times where we'll need to contact particular experts for their input and advice, and really hope that you will be willing and able to join in with that. So next slide. So what now? The current status of our application. We submitted an expression of interest at the beginning of this month. Oh no, not this month, last month. So beginning of January. We are hoping to get the outcome of that this week. And then there is a stage 2 application deadline. We don't have a date for that yet, but it's late March. So if we're successful with our expression of interest, we'll be moving on to working hard on that stage 2 application over the next couple of months. So really, just if you have any questions, ideas or suggestions about how we approach this, the methods that we might want to be using, or people that might be keen to get involved with the work, please do contact me. There's my email address. And that's all from me, so thank you for listening.
Ruth, that's lovely, and lovely to see you again. I've put all the face and the names and things back into some order, and for anybody who's new to Wales, it just goes to prove that you will bump into somebody 10 years later. Jonathan's just put in the chat that he's really sure that members will be really happy to support you and the team as the application progresses. And we've been asked, are you linking into the Cardiff Uni Innovation MDT by our colleague Zoe from Cardiff and Vale?
There's so many different groups that I can't, I lose track of which one's which, but I believe there's one that Davina Allen is directly involved with, and she did mention it when we were talking to her. So yeah, I'm sure I'm sure we will one way or another, but we're trying to link in with anybody in that area. So yeah.
And I suppose, Zoe, if you're involved in the Cardiff Uni Innovation MDT, then please reach out to Ruth as well, or to Davina, to make sure that all of those sort of cross-fertilizations can happen.
Yes,
oh, Zoe, am I seeing you up on? I'm seeing a big thumbs up there, so that's always a good sign as well. Obviously, things are about to progress for you. You're going to know where you're going next. So please do keep the Innovation Network informed. As Jonathan said, we'd be really keen to have you back once you know a bit more, or to forward to the members what they can do to help you and what you can do to help them, no doubt, in times to come. But it's great to see you again. If we don't have any more questions, and I can't see any, Ruth, I'll let you turn your camera off and the
thank you.
Stand back. Thank you so much for today. And just before we sign off for the day, and thanks guys for making this such a sort of interactive session today. We're really grateful for that. Jonathan, we were just going to quickly talk about the next session, weren't we, to make sure everybody's up to speed and where we're going next time we all get together.
Yeah, thanks, Joe, and thank you for today. you've done a great job of kind of chairing the meeting today, and I got a chance to take a sit down and a sit back and listen a bit more intently to the sessions, which have been fantastic. So thank you very much. Yeah, we've really enjoyed your steering us through the meeting today. But yes, so the next session, the next meeting, we will be on the 3rd of May. So it's going to be a Tuesday, same time as usual. And we're going to keep following these themes as we've done with the first one being prevention, and today was access and decision making. And we're looking to the next one to be around that intervention and treatment kind of side of moving through the pathway as citizens and patients move through the health and care pathways. So similar to this one, we're looking for expressions of interest for people who feel that projects, solutions or activity that they have been involved in that might fit within that part of the system. So do get in touch. I'll put myself and Priya's information into the chat so you can get in touch with us. And yeah, please do kind of get in touch with people who've spoken today. You know, it's all about linking people up through the network and sharing that information and really disseminating it across our own network, so it just goes as wide as possible. And yeah, fantastic, really good meeting. Thank you very much to everyone for coming, and I'll hand back to Joe to close off for the meeting.
Yeah, and nothing much more for me other to say thank you for your time today. It's 2.5 hours, hopefully well spent for everybody. Hopefully in the not too distant future we'll see you all in person again. I'm getting more and more hopeful of that as time is going past. But until then, obviously, if there's anything the ABPI can do, John would not expect me to leave this without sort of saying what we do in Wales for the branded pharmaceutical industry. So anything we can do to assist you, please get in touch. And other than that, I'm going to give you about 1.5 minutes of your day left before you disappear off to your next meeting. Guys, it's been a pleasure, and I look forward to seeing you in May. Take care.